in a nutshell, I have given you must have gone through the format. So it should be, as I said earlier also, it should be in that format because that will go into the college archives. So the assignment, you can just fill in the gaps to say, I mean, I have given 10 topics. So just write on those, and about the barriers and all that, up to that you can I think it's fairly basic. You get you just describe some case that you have managed recently on those topics, and then about the recommendations. They can be really hairy and audacious recommendations, like nationwide wound care service, or sort of say National Institute of Wound Care, that sort of thing. I mean, those are hairy, audacious recommendations, but that should go in line with your the problems you faced, the topic before. So that's and the discussion is about you relate your case. It's your case with the current the topics we discussed, what we gave in these lectures, and anything else that you found. You can challenge even what was taught in these lecture series. You can say that even if this was taught as such, so such and such et al. Has said in this research that this thing works rather than what was taught in the course. I mean, that everybody learns. That's why we call you all, I call you all learning partners. So without further ado, I'll open the floor to Dr. Ranga Perera. Over to you, Dr. Ranga Perera. This is a very important lecture. Again, I'm saying. Thank you very much.
Thank you for that basic introduction, and Samadhi for introducing me for the part.
Excuse me, Ranga, your sound is not very clear.
Me? I know.
Yeah, now we can hear, but again, very,
Okay, just hold on, then I'll put the microphone and come.
Please, please, please. Yeah. And the other thing, till Ranga comes back, now we have monthly webinar series also. Last time we had a very nice talk from Dr. Hilary Fernando about the urology, the palliative care and urology. I saw a few of some of yours, you all have participated that. I'm sure you have enjoyed that lecture as well. So likewise, every month we will have a talk, a webinar. So we will post that link also to you all. So next month, Dr. Renuka Jayatis, she will talk about the nutrition support for the palliative patients. It's again a very interesting topic. So please join to that also. And number two, now we are having annual academic sessions, the college. So you all are most welcome to do abstracts, do research, and present. You can publish your research work there. The deadline for the abstract still on. It's up to 20th August we are open to get the abstracts. So think about that, and whatever you come across, your research things, whatever, you can actually publish in our journal as well. And number three, we can you talk?
Dr. Samadhi, I think you have to give the host for the Dr. Ranga Perera.
So you are the host.
I am the host now, but
Yes.
how can he share the slides?
So you have to make him host.
All right.
Ranga, can you just talk to check your... Can't hear.
But can I do, Dr. Samadhi?
Can you, okay, wait. I will make Ranga the host.
Are you all right now?
Ah,
Can you
yeah,
hear me?
yeah.
Can you share the screen?
Yeah, I was trying to share the screen.
Okay, Ranga. Now you are the host, you should share. Yeah, we can see.
Right, very good.
Okay.
So I will put this as full screen.
Yes, please.
Right. I think everyone can hear, and there are a lot of participants. I saw there are about 65 participants. Yes. So we will be discussing basically about these are the main learning objectives of this presentation. We will discuss about the wound biology. That means about how the wounds, how we classify it, what are the causes of wounds, and basic process of wound healing, and what are the factors that influence wound healing. And we will be discussing, and we will deciding definition of wounds and wound, the subject related to wounds, and little history on wound management, and types of wounds, process of healing, and phases of healing, and factors affecting wound healing. And I will just touch on the management of wounds, but that will be dealt in later lectures by the team that we are going to have when you are going through with this course of basic wound management. Definitions: a wound is defined as an injury to the body which damages the integrity of tissues or body structures. This is how basically a wound is defined. I'm closing my video. Is it all right? Yeah. And the process of healing is defined as a body's response to injury and attempt to restore the normal structure and the function, and it implies the disappearance of process of inflammation and replacement of either regeneration or repair. That means the damaged tissue is replaced by either regeneration, or when there's difficulty, when there's unable to regenerate, it will be repaired by scar tissue, basically. An ulcer is described as discontinuation of the epithelium. So if there's any epithelium is discontinued, we call it an ulcer. So if you take the history, the ancient times, the Egyptian papyrus papers more than 3,000 years ago, 1500 before Christ, they have described use of lint, animal grease, and honey as topical treatment for wounds. And actually, nowadays also they use honey as a topical treatment for wounds. And Egyptians believe that closing a wound is preserve the soul. They said if there's a wound, the soul can go out from that wound. And the Greeks has first differentiate between acute and chronic wounds. And Galen, a surgeon who had been there at that time, had made many contributions to wound and keeping of pus, how to do an incisional and drainage of pus in an abscess was described by Galen. The main scientific wound management was introduced in 1980s, and that is the time that people have learned about the wound biology, and a lot of things were contributed during that era. And loss of various factors of wound healing was extensively studied in 1980s. And our current principles of management of wounds came in 1980s. So basically, wounds are acute wounds and chronic wounds. And acute wounds, there can be contusions, abrasion, a hematoma formation, and a clean incised wound, laceration, crush wounds, penetrating wounds. These things are basically traumatic wounds that we encounter. And chronic wounds are basically due to chronic problem like chronic ischemia and conditions like chronic ischemia leading to the wound is not healing, and whatever the cause that had been healing there, it causes healing, difficulty in healing, like arterial ulcers in the heel and legs, and the venous ulcers that we get on varicose vein and deep venous insufficiency, and neuropathic ulcers, which you usually find in the pressure point areas like soles of the foot, like diabetic and commonly decubitus ulcers. Those are the bed sores of people who are bedridden for a long time. So those are also coming to neuropathic and neuroischemic ulcers. And these are chronic wounds which can be either spontaneously generated or maybe continuation of a simple traumatic event. Vasculitis is another cause like that which can cause chronic ulcers. Now, if you consider the basic physiology of wound healing, there are two processes we discussed. One is regeneration. That means the healing takes place by proliferation of parenchymal tissue. That means the damaged tissue, whatever the damaged tissue cells, and usually results in the complete restoration of the original tissue. So the damaged tissue is completely restored, and there's no replacement by repaired tissue. So complete organ is replaced. So for example, the liver, if you remove a part of liver or there's a part of liver undergoes necrosis, the whole thing will replace by regeneration of tissue. There is no scarring. Repair is when there's healing takes place by proliferation of connective tissue elements resulting in fibrosis and scarring. So if a tissue got damaged like skin, a muscle, like especially the cardiac muscle, a nerve. So if the gap cannot be closed by regeneration of parenchymal tissue, the damaged tissue will be replaced by scar tissue and fibrosis, and there will be non-functional tissue of that organ. That scar tissue is not functional thing. The tissues are, the tissue has their process to function. That function cannot be continued by the scar tissue, but structure is regenerated. So we'll go by regeneration. So some parenchymal tissues are short-living. So some parenchymal tissues are very short-living, like intestinal cells, skin kind of thing, very short-living and very short lifespan. it just goes off and it will be replaced by new cells. So these cells can be regenerated very quickly. So like skin, epithelial tissue in intestine, and epithelial tissues of the bladder, bowels, and renal kidneys. These things are replaced by surrounding tissue immediately when there's a damage. So there are a lot of factors needed for the regeneration of tissue. So there are these factors are found in 1980s, most of these factors, and they are described as epidermal growth factor, fibroblast derived growth factor, platelet derived growth factor, transforming growth factor beta, and endothelial growth factors. So these things are short term like EGF, FGF, PDGF, TGF beta, and EGF2. So proliferation of original cells on the margin of injury with migration so as to cover the gap is the first step. So when there's some tissues were removed or some tissues were damaged by injury, the surrounding tissue at the edge of the damaged tissue will proliferate and close that gap. These marginate cells are subsequently differentiated and mature into a reconstitute the original tissue. So the tissues which they can completely regenerate the damaged tissue. That is called regeneration. But mostly what happened is repair. The repair is a replacement of injured tissue by fibrous tissue. There are two processes involved, that is granulation tissue formation and wound contraction. So repair response takes place by participation of mesenchymal cells, that means fibroblasts, not the parenchymal cells, the mesenchymal cells, that means supportive tissue cells like connective tissues, fibroblasts and histiocytes will come, and then endothelial will come there, and macrophages will come for the wound healing part, and those things will replace the damaged tissue, not by the original tissue. So repair has three phases. First phase of inflammation. That means if there's any damage to the tissue following trauma, there will be inflammation. So the wound gap is first covered with the blood clot of the injury, and there'll be acute inflammatory process going on, and neutrophils and monocytes will come there within first 24 hours and try to fight against the bacteria and other pathogens which will try to enter into the body systems. And if the patient is immunocompetent patient, the body will overcome the pathogens which are trying to enter into the body system. The second phase is a combination of proteolytic enzymes liberated from the neutrophils enzymes and from the macrophages and the phagocytic cells will clear the necrotic tissue. The damaged tissues will be completely destroyed and cleared by the body inflammatory cells. And second phase is growth of granulation tissue. The damaged gap will be covered by granulation tissue. That means it's basically containing of small blood vessels like capillaries, fresh blood vessels like capillaries, and fibrogenesis. That means fibroblasts will come and produce fibrin and collagen layer, and there will be a lot of new blood vessels inside that is called the granulation tissue. The granulation tissue has two parts, angiogenesis and fibrogenesis. The formation of new vessels at the site of the injury take place by proliferation of endothelial cells and from the margins of the damaged blood vessels. So new blood vessels will come from the damaged corners of blood vessels and start proliferating into the wound. Grow the blood vessels will grow into the damaged wound area, which is now covered by a blood clot. That blood clot will be gradually invaded by the blood vessels. The angiogenesis is stimulated with proteolytic destruction of the basement membrane. Now, when there's a damaged tissue, there will be epithelium, and the epithelium will always have a basement membrane. So when there's proteolytic destruction of the basement membrane, the blood vessels will grow very quickly on that area and cover that damaged tissues. So vascular endothelial growth factor is very important in this mechanism of healing, and platelet-derived growth factor, which will always be there in a damaged tissue because the blood clot will be there, and blood clot will have platelet, and platelet will secrete this platelet-derived growth factor. And the transforming tissue growth factor beta, TGF beta, is also there from damaged tissue. Fibroblast will produce this tissue factor. Other cytokines will also help in the inflammatory process, the inflammatory system, interleukins, cytokines. Those will all stimulate the blood vessels to grow, the angiogenesis. So the second phase is the wound starts contracting because of this granulation tissue containing fibroblasts, and fibroblasts will produce collagen, and there are special cells called myofibroblasts in the appearing the granulation tissue, and the myofibroblasts will contract the wound starting from day 3 to, and it will be completed by day 14. These cells have an intermediate shelf between fibroblasts and smooth muscle. So they are containing actin and myosins, and they will produce contracting activity of the wound, and wound will ultimately heal with contraction of tissue. If you take this thing more detail, so healing in primary intention, that is intention in primary union, it's just like an incised wound, just like a surgical wound. We clean cut like this. The patient is having a clean cut like this. The first place is initial hemorrhage, so the cut will covered by hemorrhage. There will be a cut blood vessel also, and the blood will come out and close the gap. And the gap is now the hematoma, or the blood clot, will be coming in the first 24 hours. There will be inflammatory cells will come to this area, and they will try to fight with the bacteria which are trying to come through this blood clot. And later, this neutrophils will be replaced by macrophages. When the macrophages come here, the macrophages will dissolve this blood clot, and they will produce various growth factors like tissue growth factors, fibroblast stimulating factors, and those will activate the fibroblast to come here and replace the fibrin from the clot with collagen. And later phase, this will completely heal by scarring tissue in the fibrous union. But the epithelium here, can you see the epithelium? Epithelium has fully regenerated, but underneath scar is replaced by fibrous tissue. The upper part completely replaced by granulation by epithelial tissue. So primary union, again, I'm just making sure you remember it very well. The basal cells are proliferating in margins toward the incision. So the basal cells, they are in our wound, will come and proliferate into the tissue. And wound is covered by a layer of epithelium in 48 hours. So the epithelium will cover in 48 hours. I'll tell you what is this. This is suture tract. So remember now, when we are suturing the wound, there will be a track of thread going like this, and this is the suture track will also take part in this process of healing, and there is a gap because the suture is there. So more you keep the suture, the more time you keep the suture, there will be more reaction for the suture. So immediately, if you can remove the suture, that is better. If you can remove the suture within 3 to 5 days, that's better. But here at the moment, this is the suture track is there, and that is also part of the wound. So the marginate epidermal cells will separate the underlying viable dermis with the formation of necrotic material and the clot of fibrin scab. So when the epithelial tissue will come and completely cover this area, the scab will be pushed outwards, and the underlying tissue is separated from the scab by the cells which are coming here in this region. So the basal cells of margins continue to divide, and there are more and more cells will divide and completely cover this area. This is the time that we usually remove the sutures, and we remove the sutures, that gap is also will be completely covered. By the 5th day, multi-layered new epidermis will form into differentiate into superficial and deep layers, and they will completely heal this area by collagen, and the skin epidermis will completely regenerate, and there is no epidermal problem, completely regenerated. But the dermis, which is the differentiated tissue, will be replaced by fibrous scar. So primary union, the next step is organization. This one is organization. By 3rd day, fibroblasts will invade the wound area. By 5th day, new collagen fibers will start formation, and 4th week, the scar tissue will only scanty cellular there, only there will be very small amount of cellular part will be there, and completely replaced by fibroblast. Now, what is the secondary intentional healing? Now, compared to primary healing, the gap is much more. There's a big gap here, and not like this. Now, the scab will take longer time to complete this, to form a scab here like this. To for within 48 hours, this gap will be filled by in the primary intention, but it still take longer time for the epithelial cells in the margin to come down here and close this gap and separate the granulation, separate the underlying damaged tissue of the dermis from the superficial part. So there's a longer time. So anything else can happen, like in the infection can go in, foreign bodies can be kept there, and infection can, the bacteria can go in more time, and any damage to the scab there during that period will again have a fresh wound. So it takes longer time to heal by secondary intention. But it's the same process, same growth factors, and same principles apply. So if you take the complications, what are the problems of wound healing? Number one is infection. Now, if you take this primary intention and secondary intention, the chances of infection is much higher, because by first day, by day 1, or within 48 hours, the wound, the internal part will be separated by the epithelial cells in primary intention, but it will take longer time in secondary healing. If the wound is large, it takes longer time for it to take that part, so there's a higher chance that it can have infection. Implantation of substances, that is, when you're suturing, you might suture it, the skin organelles like sebaceous hair follicles can get implanted inside, so they can get a implanted dermoids. Pigmentation is a common problem there. Usually scars can be hyperpigmented, sometimes hypopigmented. Pigmentation is a very common problem. Deficient scar formation. Scar is not forming better. There are problems of scar tissue formation. Wound is not healing properly. We'll come to that later, what are the causes for that. And hypertrophied scars and keloid scar formation. So I'm not going to detail what is the difference between hypertrophied scar and a keloid scar. So scar, when there's scar tissue formation, the fibroblasts will lay more collagen than what is necessary to be filled, and there will be more. The scar is bigger than the wound. That is what we call keloid and hypertrophied scar. And if the wound is there for a long time due to various reasons is not healing, it can undergo malignant transformation. Any scar tissue can undergo malignant transformation. Commonly, it happens in a large scars like burn scars, things like that. But any scar tissue and later undergo a malignant transformation. So, if you take factors of wound healing, what are the factors which is wound healing? We basically classify them into local factors and systemic factors. Local factors are number one is infection. So if wound will never get infected, will never get healed if it is get infected. And poor blood supply. This poor blood supply includes arterial insufficiency, venous insufficiency, and also neuropathic thing, because when there's no sensation on an area of the foot or body or any area, if there's no sensation, the person will stay in that position for a long time without their knowledge. So that tissues are compressed due to body weight for a longer time than usual. So the blood supply of that tissue is not going to get adequate oxygen and nutrients, and there's no adequate waste product being delivered out from that tissue area which is under the pressure. So that areas will undergo the pressure necrosis and a new wound will develop. And if there's already a wound, that wound will never heal. So all these are local factors due to poor blood supply. Movement. So if the wound edges are moving one another all the time, like in areas like skin flexures, like knee joint, like elbow joint kind of areas, there's constant movement. So if the constant movement is there, it is difficult to heal. If that wound is exposed to ionizing radiation, sometimes when you are done surgical procedures and then they should be given radiotherapy, and if the radiotherapists will always make sure that the patient is completely had wound healing for them to give radiotherapy. If they give radiotherapy prior to wound healing, it will not get healed after that. And secondly, also, if you are getting a wound, they are doing a surgical scar, they are in already area where there's undergone radiation, there will be difficulty in that area to get a wound healing. That is basically because the angiogenesis part. The angiogenesis is disturbed by radiation, and there will be poor angiogenesis in that area, and there is no proper wound healing. Foreign body. Now, if there are foreign bodies entrapped in a wound, maybe a piece of suture that we have forgotten to remove, or contaminated with soil or any other material, that wound will have a difficulty healing in its process, because the foreign body will have always there will be a reaction to expel that foreign material out from the body. So for that reason, it is not healing. Secondly, the foreign material can harbor infection and keep bacteria inside that region, and that will also prevent the body to be healed. Bone involvement. That means if a wound is involved, a bone, periosteum, underneath periosteum is exposed, or bone is exposed, or bone is infected due to some other reason, there's long-term wound problems will be there until that infection of the bone is taken out. Sometimes we might have to remove the whole bone and do a bone graft for it to heal. If there had been long-standing ulcer, long-standing wound, it had undergone malignant transformation, that wound is also never healed until it will be treated properly by surgical excision and replacement with skin graft or some other flap. Systemic factors, age, older the patient, difficulty for them to heal the wound. Younger the patient, it will be healed very quickly. And if the patient is very young, like a neonate, within the first 10 days of life, the wound will heal without scarring, because at that time, the scarring process, the wound is so well regenerative. The skin is regenerative, so it can regenerate the skin also during that time, and there will not be any scars. Nutrition, very important. The wound, if you take as factors of main factors of wound healing, nutrition, blood supply, and infection. If these main three things are managed, any wound can be healed properly. So nutrition is very important. We have to think about the things that important in wound healing, the nutrient contents. Wounds are covered by collagen. Collagen is basically made from protein. So protein is very essential nutrient component. Other than that, zinc, vitamin C, and vitamin A are very important in wound healing, because collagen is made up of protein, and vitamin C is required for hydroxylation of collagen, hydroxyproline, and these are the main active components of wound. And the zinc is also very important as a cofactor in this process. The wound healing is required proteins, vitamin C, and zinc. Other than that, we can't treat the patient with only proteins and vitamin C and zinc. You need all the other components also to make sure the energy is there. So you need to have a very well balanced diet and make sure they have supplements of vitamin C and zinc and protein. Systemic infection. If one is having a systemic infection, that is also a problem. It will delay the wound healing. Uncontrolled diabetics very commonly cause problems of wound healing. Hematologic abnormalities like vasculitis and conditions like sickle cell anemia cause difficulty in wound healing. Any chronic organic disease is very important when it comes to palliative care. These patients are having malignancy, either congestive cardiac failure, COPD, and chronic liver failure, and chronic alcoholic chronic liver disease. So any of these major organ failures will cause delay in wound healing. So the main factor of delaying wound healing may be the systemic illness the patient having. And there are barriers. These are, other than the main factors, there are some other barriers which causes difficulty in wound healing. So we can continue on the barriers like client factors, the patient factors. Receptive to planning and already has plans. So they should be receptive. The patient should be receptive for a plan. Now, patient need to have their own idea of they need to heal this wound, and they should be given a plan. This is the way that it should be explained. Your wound is not healing because of poor blood supply. This is our plan. We need to do an angioplasty or things like that. You need to explain the patient and have the plan, and patient should be receptive and should be happy to undergo that plan. Our barrier is we refuse to talk about future needs. They only want to heal the wound in next day, right? They don't want to have the plan, right? So financial problems, unwilling to discuss the unexpected plan, unable to participate in planning, and cognitive impairment. They don't understand what they're telling. They don't realize what is the problem. I think it's the family. They need to have good family support. So available family caregiver may not be available. There should be someone to dress the wound. There should be someone to care for the wound. There should be someone to give the good nutrition. So these things are things. The family should also be involved in the planning. They should also understand what is our plan to contribute to wound healing, and they should understand that plan. Right. So number one is lack of family. Some of them they don't have anyone in the family. They are living on their own or in road or something. Right. So difficult to access the family. No previous relationship with the family. Difficult family circumstances. Family is unaware of the need. Family is don't want to know the need. Family doesn't come there to see the patient even. So those kind of problems we face difficulty. These are the barriers of wound healing. Case manage, knowledge of planning and previous experience of planning. So they don't have their awareness of the wound, the reason for the wound is not there anymore. And they're not comfortable with the plan. And there's lack of training and education. Program. Project the lack of funding and focus on the current case needs. But we need to have financial plan to do the needful. The system. That means our system, the health system of Sri Lanka. So this is what we always find this problem there, a lack of communication with the providers. We talk to the patient, sometimes we talk to someone else who is coming there. So these patients are chronic patients who are there in the ward for a long time. And we tell that the bystander, not even a relative, is a paid bystander. So there's lack of communication with the family. So unaware of the provides unaware of the case manager. A little bit about the microbiology. So we discussed that infection is part of difficult. Infection is a part of wound healing, delaying wound healing. But sometimes some microbes are helpful, like maintain the skin barrier, like the Streptococcus epidermidis, and pathogens. The other pathogens will be expelled by this kind of bacteria, and pathogenic bacteria, they will break down the skin barrier and produce toxins and proteases and form biofilms. When there's biofilm, whatever the local applicants that we are putting onto the wound will not go into the wound to enhance healing. Pathogenic microbes, increase pathogenic microbes, increase oxidative stress there, and tissue cell death will be increased, and lymphocyte function will be deprived by this, and wound healing will be poor, and it will reduce the commensal microbes, which is good for wound healing. The common organs which are positive problems of wound healing are pseudomonas, very difficult to treat them. When a wound gets infected by pseudomonas, there will be greenish slough will be there and very difficult to remove it from the wound because pseudomonas doesn't need that much of biological tissue for them to stay around there, and very difficult to treat Pseudomonas. E. coli is one of the commonest pathogenic organisms of wounds because it's coming from the gut, and we all are having gut commensals around the perineal and buttock areas. Common big problem for bed sores and even other areas of the body. E. coli is one of the major infections in wound infections these days, and Streptococcus and Staphylococcus are the commonest organisms other than E. coli of chronic wounds, especially MRSA. And you can see this wound very badly damaged, necrotic tissue, the plantar fascia, and its necrosis, and we might have to end up in a amputation. That will be all. And any questions in this? I am free to discuss. Any questions?
So I have a question.
Yes.
Any chronic wound, is there a possibility of undergoing malignant changes? Any chronic wound?
Yes, any chronic wound, if there has been long, depending on the time period, it can undergo malignant transformation.
If so, it's usually squamous cell carcinoma rather than basal cell carcinoma, right?
It is always squamous cell carcinoma. Basal cell carcinoma arises from de novo. Usually it arises from as an ulcer from the beginning. The chronic wound will never undergo basal cell carcinoma. Usually primarily it's basal cell carcinoma will appear like an ulcer, but it will never, the chronic wound will never become a basal cell carcinoma.
Okay, thank you.
Anything else?
The role of papain, papolkiri.
Yes. Yeah. It depends on, there are, I didn't talk about any material that can be used for wound healing. It will be discussed in a future sessions. But anyway, papain, maggot therapy, even honey, there have been many things have been used. Papain has been used for wound healing. It is actually shown in some chronic wounds. It works very well. You have to decide, which media to use depending on the factors of the wound. First, when you are when it comes to the positive factors of wound healing, first you need to understand why the wound is not healing properly. Then you need to find out that treat that root cause. Otherwise, it will never starting to heal. You need to find out whether the blood supply is good. You need to find out whether there is any infection going around that area, and you need to find out whether the blood supply is good. And if those things are good, if the still is still not healing, the wound cover, so that supportive to wound healing. Then you need to find out whether there's any infection going on in superficial colonization and things like that, or is there a lot of stuff there in the wound, or if the wound is very, very exudative, it is coming a lot of juice coming out. So all these things we need to decide which dressing to be used. So papain is there to, when there's a lot of slough there, you can use papain as a proteolytic enzymatic wound debridement, and that papain will destroy the slough, deslough the wound there, and it will enhance the granulation tissue growth.
Okay, thank you, sir.
So,
Yes.
how do we identify malignant change in a chronic wound?
Well, one thing is the wound is not healing properly. That's one. And the wound edges, the classical wound edges, there are types of wound edge. The sloping edge is a healing ulcer. Punched out edge is usually a decubitus ulcer or a pressure ulcer. An undermined ulcer is a tuberculosis ulcer. The wound is going, the edge is going under the surface of the wound, right? And other thing is a rolled up ulcer. That means the wound edge is going above the skin area. And other thing is inverted ulcer. Wound edge is coming out from the skin area to normal skin area. So when that either rolled up or inverted edges are the hallmark of malignant transformation. So you need to take that edge of the ulcer as a biopsy, and then only we can say it's a malignant transformation.
Hello, sir.
Yes.
I have a little question, sir. So, how do we decide to do proper wound toilet? As in this case, are we going to suppose exercise all the necrotic tissue in the first instant, or we just keep it to demarcate and do it in the second time?
Well, the first wound toilet is the best wound toilet. So whatever if the wound is necrotic, you have to remove necrotic tissue completely. You can't keep it.
Okay, thank you. Sir, if in this case, then most of the soul is involved. So
Yes.
the concerning about the function and the future, the patient condition, we have to remove all the necrotic tissues and do the proper wound toilet.
Yes. You need to remove all the necrotic tissue. No point of keeping the necrotic tissue. That will make the patient septic, and that will make the patient more prone to the infection to spread all over the heel. So the first go, remove the tissue as much as possible until you get good healing, and remove all the necrotic and necrotizing tissues, and do a good thorough drainage of pus and good thorough wound irrigation with a lot of saline, and remove all the necrotic tissue and pus out from there. Then you put good healing and see whether it is granulating. If the tissue is granulating well, then you can put a cover. If the heel is sealed, the calcaneum is exposed, probably good moisturizing cover will cover it and granulation tissue will come up. And if the wound is just starting to heal, and if the blood supply is good, and if the wound is healing, then you can think of putting a flap there and cover that area of the heel. So no point of keeping dead or dying tissue just to cover, cover a bone or something. You need to remove that.
Thank you, sir.
Sir, what's the role of antibiotics? So when to start and how long should we continue? Surgical clinics and all, sometimes the cultures do get positive for certain organisms, but doesn't like we don't see any evidence of infection, sir.
Yeah,
So
that means the wound is getting colonized. So there are two ways to the bacteria can be there as colonization and infection. So if the wound is colonized, you don't need to treat systemically those patients. You only need to treat locally. So local antiseptic dressing will cover that colonization. If the patient shows systemic infection, that means surrounding area of the wound is inflamed. patient is running systemic infection like fever. And if there are, when you're pressing the surrounding areas of the wound, if there are pus coming out from pus tracks, then there's systemic infection and there's wound. You need to admit that patient and give. But if a granulating wound, SOPs are giving cultures like, streptococcus is there, streptococcus is there. It doesn't mean anything unless there is patient showing systemic features or active pus is there. In that kind of case, if there's no pus or no necrotic tissue, then you can treat the patient with local antiseptics. No need to give systemic antibiotics. If there's any infection, ongoing infection, that depends on your systemic infection. You give antibiotics systemically for a period of 5 to 7 days, depending on the antibiotic that you are using, and see a culture again and see whether the infection is going down on systemically by your systemic parameters like full blood count and CRP. If those indicators are showing that it is coming down and is getting healing, then you can change into oral antibiotic and keep it for about another 1 week, and then you can decide whether the patient can be discontinue or continue antibiotics.
Thank you. So depending on the when you're planning to put a skin graft or something, if the culture gets positive for certain organism,
yes.
So like then we continue antibiotics and eliminate the commensals first, or how?
So if it is positive for microbes like Streptococcus aureus and beta-hemolytic streptococci, those can destroy the graft, no? In that case, you can treat it. No need to give antibiotics. There are no systemic signs of infection. No need to give antibiotics, but you can treat the patient with local antiseptics, like active povidone iodine alternating with chlorhexidine or triclosan or things like that can be used for drilling. Even the new products like Acticoat and what else, the biotin silver kind of medicines can be used. That part to be discussed by others in the late part. Don't worry, we are discussing those things.
Okay, thank you.
Anything else?
So I just want to know more about biofilm, regarding biofilm.
Yeah.
So whether is it visible to naked eye, or how can we diagnose a biofilm?
It can be visible to naked eye. If you see it properly, if you see the wound, a granulating wound or infected wound, you can see a thin layer of kind of a film-like thing is there in the wound, covering the granulation tissue. It can be seen very nicely.
Shall I barge in? It's like jelly. If you see jelly,
it's like a jelly.
About 99% it's a biofilm.
So the biofilm, is it beneficial for the wound?
No, not beneficial. No, not at all.
So then, sir, is it or not only collection of bacteria? It's a collection of some debris and bacteria. Or what
bacteria and fibrin and bacterial byproducts. They all contain the biofilm. It covers the wound. It will prevent the, we are putting things outside. We are putting the dressings and some bacterial product and local products to heal wound, so that things will never touch the wound, even there's biofilm.
So that means biofilm needs systemic antibiotic, no?
The biofilm needs wound, debridement and removing it.
Yeah. Okay.
Mechanical removal.
Okay.
Now what biofilm does is actually it keeps the wound in the inflammatory phase. The wound is stuck with the biofilm in the inflammatory stage. So it just tries to eliminate it, and whatever you put is from top is protected by the jelly layer. So you have the jelly layer, and then you have these active bacteria, active phenotypes of bacteria. Then you have these dormant layers and pores at the bottom, and they are very intertwined with all the fibres and all that. and nothing will penetrate from down no up. So it's a thickly woven layer. And sometimes it's not only one organism, there can be many
multiple organisms.
Like sometimes Proteus and Pseudomonas. Mostly the jelly-forming things I have seen Proteus and Pseudomonas. So the systemic antibiotics does nothing. Only way to remove is either corrosives or cut and remove it. So
Yeah, cut and remove it. Mechanical removal of things like Milton solution, sodium hypochlorite, those kind of thing, and even papain might work.
Okay.
So in a wound with biofilm, the antiseptics they might not work, no sir.
They not work. They can't reach the wound.
Okay, thank you, sir.
Again, this is where I in last week's lecture I said we try 100 rupee dressing, then 500 rupee dressing, 5,000 rupee dressing. That is where that scenario happens. You have a biofilm, you try everything, for putting one dressing day. After 2 weeks, you are putting another one. You put the most advanced and most expensive dressing. That's how you get carried on with the biofilm.
And the wound dressing companies will thrive.
Exactly.
Any more questions? Any more queries?
Sir, I have one question. Is hydrogen peroxide accepted antiseptic anymore, sir? Or how does?
Now it is going out of fashion actually. Now they are not using hydrogen peroxide. Hydrogen peroxide was used when actually it was used, long time ago when tetanus was a kind of a major infection during farmyard injuries and warfare injuries, and to keep that, the tetanus is a obligate air anaerobe. So if when there's oxygen, tetanus bacteria will die. That's why they use hydrogen peroxide, because hydrogen peroxide will ultimately produce oxygen and destroy the pathogen. So now it is not being used very commonly. Two things that it said, the oxygen free radicals will damage the tissues.
Yeah.
And the healing granulation tissue and things like that will damage by oxygen free radicals coming from hydrogen peroxide. So now it is going out of fashion and it's not being used at all. For the last 10-15 years, people are not using peroxide.
Thank you, sir.
Any more? Shall we conclude this session then?
Yeah. Any more questions from Dr. Ranga? Okay, then we can conclude this session.
There were some questions on the chat. Someone was asking some vitamin